sugar is absent,
Okay, so
and
what,
RBC
so what's your interpretation overall?
The patient having both nephritic and nephrotic pattern of disease.
Nephritic and nephrotic background. But what else is there in this patient? Something that is what is the most worrying thing in this case?
So
these are the abnormal ones. No? These are the abnormalities that you find. So what is it that should worry you the most?
Serum rising serum creatinine.
Exactly. Serum creatinine is high. So this is a
nephritic
renal failure.
Renal failure.
So renal failure is the problem here.
Proteinuria.
And is it a renal failure that has appeared over a long period of time, or is it something very short?
It is weeks to month.
Weeks to months, what do you call weeks to months? Something occurring in days you would call as acute, isn't it?
It's a rapid
something occurring in days is acute. Something occurring in years you will call it chronic. And something weeks to months you would call it. Previously we used to call it subacute. And even this morphology that I'm going to show you in my student days, this used to be called a subacute nephritis. It's an obsolete term. Nobody uses this something more. But now we call another name, very rapidly appearing renal failure. So this is likely to be a rapidly progressive renal failure. Okay. So possibility of RPGN is one of the reasons frequently you do a renal biopsy. And we will discuss why renal biopsy is done in such a case.
There is two renal core biopsy pass stain slide showing glomerulus tubules with RBC cast and few dilated and few atrophied tubules with interstitium. Yeah,
but tubular atrophy is not all that much, no? Here there are some atrophic areas you can see, but it's not all. This is all medulla. Here again, my pointer is gone. Okay, this is all medullary tissue, where tubules will be slightly separated from each other. But some atrophy is here. But there has not been enough time for tubulointerstitial damage to really take hold. Whole thing is so suddenly appearing. And you find this large glomeruli. Very large. So we'll see this under higher power.
High power.
This is one glomerulus. This is
the
normal or abnormal? Normal or abnormal?
There is disruption of capillary lumen.
No. This is the section is not probably not all that good, but this is fairly okay. This glomerulus doesn't look very abnormal, but this one does. So what is the abnormality that you see in this glomerulus?
Disruption in the mesangial matrix.
Okay, so do you find the normal elements of glomerulus? Like here, you have the normal glomerulus. Here again, this is normal, more or less normal. So here, you don't find that. That is very compressed. This entire glomerulus is only this much, this tiny little thing. So all around you have extra capillary proliferation.
Yes.
Okay. So this is what we call as though this is not really crescent shaped. This is what we call as crescents, glomerular crescents or extra capillary proliferation. So this again I show under high power. And what are these composed of?
Yes, sir. It is composed of epithelial cells, fibrin, and inflammatory cell infiltrate.
Inflammatory, particularly macrophages. And there will be some fibrin will be there, and there will be extracapillary proliferation. And this whole tuft is compressed to a very small kind of tissue. We can't make much in this tuft. And this again shows some. This is a vessel. Seems to be somewhat thickened. So what are the approach? Now your basic diagnosis is what?
Crescentic glomerulonephritis.
So once you make a diagnosis of crescentic glomerulonephritis, how will you approach further?
I would like to further do investigation, electron microscope and immunofluorescence.
Okay, electron microscope first or immunofluorescence first?
Immunofluorescence first.
Electron microscope is not all that easy to do. You have to send it. Most centers won't have it. You will have to send it somewhere to another center. But Fluorescence is something that you can do straight away, and then you can really get to know what it is. So why do you want to do that? How will you distinguish using just a simple immunofluorescence? What are the three major types of crescentic glomerulonephritis?
There are
three
three
major
types
causes.
of three types of crescentic glomerulonephritis. Type 1 is antiglomerular basement membrane. On immunofluorescence, there will be a linear pattern of immunofluorescence. And on second, immunocomplex deposition, there will be granular discrete pattern of
Very good.
deposition. And type 3, there is no deposition. Negative for
So in that case,
immunofluorescence.
what is the most common cause?
C granulomatosis with polyangiitis.
Okay, so ANCA base. So
ANCA,
C or P
yes.
ANCA related glomerulonephritis. So that is what anti-GBM immune complex, which may itself be infection related or secondary. And secondary means various, even lupus nephritis or Enoch-Schonlein purpura, many other diseases can present as crescentic nephritis. Even IgA nephropathy can sometimes present as, then you call it as IgA vasculitis or Enoch-Schonlein purpura. Then the posse-immune, various causes. Few cases you may not get an answer, posse-immune without a particular answer. ANCA may be negative. So this is a granular immunofluorescence. It would look like this, whereas a linear should look like this. It's a continuous line, like you've drawn line with a pencil. And you do this ANCA in what tissue? What do you do ANCA? Do you do it in the renal biopsy or in the blood? Blood. The antibodies will be in the blood. And these neutrophils are target tissues that you use to see the pattern of fluorescence that you see. And you can do by other immune tests also, P-ANCA and C-ANCA. This case, I'm sorry, I'm not 100% sure this is this particular case or some other case. So, but as an example, I'm just showing that this is IgG and C3 positive, and so you would diagnose it as crescentic glomerulitis, immune complex mediated. But I have a doubt that the case that I showed is probably not this one, maybe another one, ANCA related. Are there any pointers to say in the histology that the cause is ANCA vasculitis? You frequently find glomerular tough necrosis are there, then vasculitis may be there. So you strongly suspect that this is ANCA related disease. And if you find a lot of neutrophils, a lot of exudation, then this is more likely to be proliferation and exudation, just as you see in usual IRGN that we saw earlier. No? So if the tuft is showing those changes, then it is likely to be immune complex disease. Okay, so I think we will go to the last case. Dr. Alex, would you want to discuss this?
Yes, sir. Oh, yes. So this is a 78-year-old male.
Okay.
So the case is a 78-year-old male with normal glomerular filtration rate till 2 months ago. So currently presented with progressive constitutional symptoms and a deterioration in the glomerular filtration rate, with creatinine rising from 2.6 to 5.0. So blood investigation showed a hemoglobin level of 13.7 gram per deciliter, which is normal for this age group. Serum creatinine was 5.0 milligram per deciliter, which is elevated. Serum albumin was 4.1 gram per deciliter, which is relatively normal. C3 was normal. Urine showed mild proteinuria, which is nephrotic level. He had no glycosuria since sugar glucose was nil, and he had hematuria of 20 to 30 cells per high-power fluid.
Okay, so these are the abnormal ones. So what would you call this? What is it that we should be really looking at?
So, sir, from these laboratory investigations plus the clinical information, probably this is not a nephrotic syndrome.
Yeah, it is not. Yes, agreed.
Yes, but maybe it can point more to chronic progressive kidney disease.
No, but normal GFR till 2 months ago in the history. So
Oh,
this
yes, yes,
patient
Professor,
was
sorry.
absolutely normal, till 2 months. And suddenly you are finding that there is renal failure. So what you would think in terms of a more acute process, isn't it?
Yes, Professor. Yes, doctor.
So it is an acute process that is developing over 1 or 2 months. And so you would think in terms of an acute renal failure or more acute kind of kidney injury.
Yes, doctor.
What they like to call now as AKI, acute kidney injury, something.
Kidney injury.
And frequently,
Yes,
we are asked to give an opinion and asked to say what is the reason for this AKI. Okay, so let's look at the slide. Right.
So, sorry, I'm a little bit, my network is a little bit sluggish, but now I can see the section.
Okay.
So on the section, there are two renal core biopsy showing predominantly renal tubules with very scanty glomeruli. At this level, I can ascertain only one glomeruli, which is close to this large blood vessel on the right side.
Okay, can I put a question to you? See, we have seen some renal biopsies earlier on, some in which the focal areas of when the interstitial tissue, tubules are separated from each other. We say that there is interstitial fibrosis or chronic. Here also you find a lot of interstitium, the tubules are all separated from each other. Almost uniformly, uniformly everywhere, the tubules seem to be separated from each other. But there has not been enough time for the so much of chronic renal failure to develop. Because 2 months back, we know the GFR was normal. So what alternatively could be the reason why these tubules are separated from each other?
The reason of this broad interstitial space is due to edema.
Very good. Excellent. So there is edematous. So higher power maybe will be able to make this out better. So you think that there is when there's such a uniform thing, short duration, this is likely to be edema.
Okay. Yes, doctor.
So now we know the reason, no? See, look at the slightly bluish kind of material all in between. So this is edematous, an edematous renal tissue. And among this edema, what do you find?
So in this edema, there are also mixed inflammatory cells.
Inflammatory cells. Okay. Which inflammatory cells?
Yes.
What kind of inflammatory cells? If you can make out. Otherwise, higher power will.
Sorry.
What do you think? You want to go higher?
So at high power, the majority of the inflammatory cells probably they are lymphocytes.
Lymphocytes. Any other inflammatory cells?
But also I still see some eosinophils.
Yes, very good. Eosinophils, 1, 2, 3, and the rest are all lymphocytes, an occasional plasma cell here. See a few plasma cells.
Yes, doctor.
So lymphoplasmacytic edema, lymphoplasmacytic infiltrate, few eosinophils, and the result is that very dramatic renal failure has developed. So what would you call this?
So this one I would call it as an acute tubular interstitial nephritis.
Very good, very good. So the diagnosis is an acute tubulointerstitial nephritis. Now, does this picture give you any clue regarding the cause?
Sorry, doctor, I'm a little bit beyond. So I will have to take some time to wait until the slide show up.
Oh, sorry. No, this is the same slide. We are on the same slide.
Okay.
So with this picture of eosinophils, what would you think in terms of the cause?
So in terms of the cause, having neutrophils in the interstitial space, having eosinophils, So this can be foreign substances such as drugs, but also parasitic infection.
Okay.
Of
So,
which I don't think if it's the case on this case.
very good. Particularly drugs. So when you see a lot of eosinophils in this infiltrate, it usually points to a drug. And if you take a history, there'll be a history of some antibiotic or like aminoglycosides or some antibiotic usage in the recent, just prior to that. That is very, very common to find that. And sometimes you find this lymphocytes invading the tubules also, so-called tubulitis. Similar to what we see in transplant rejection cases, you can see, look at this lymphocyte. So this is tubulitis. So even tubulitis sometimes you can see in this. And this is an acute tubulointerstitial nephritis, as you very rightly pointed out. And this is the very large number of causes that you. So you have to inquire regarding these causes and see, particularly drug history. Sometimes some infections, many infections can produce this kind of renal failure. I think we have end of the case. So we have left out one person whom I didn't ask the question. So Ananya.
Yes, sir.
The next question is to you. See, I said that many cases of acute kidney injury, they do renal biopsies, and we have to give an answer. And this is one of the areas where frequently we can really help them, in managing these patients by giving an immediate answer why this acute renal failure has occurred. So I'll show you two pictures. A few other common causes of acute kidney injury, and you tell me what they are. The left one and the right one.
The left one shows tubular necrosis, sir, acute tubular necrosis.
Very good. So when you see a picture like this, they send a renal biopsy. I mean, they wouldn't send a renal biopsy to you in a case of accident with massive shock and other things where there is renal failure. It's not needed. They know that if there's renal failure, it is due to acute tubular necrosis. So non-obvious cases, when you find acute tubular injury, what are the causes that you would think of?
It can be drug-induced or toxin-induced or uncontrolled hypertension.
Okay, particularly toxins. Toxins are one clue. It can produce that. Various kinds of toxins producing ATN. What else? Infections? Any infections? There's history of fever also?
Yes, sir. Like polyomavirus.
Polyomavirus, I'm not really very sure. I've never seen. Leptospirosis is one case where you can find interstitial nephritis as well as tubular necrosis sometimes. What else? Another thing that we have to guard against. Another thing that I've seen is usually snake bites. Snake bites which go unrecognized, sometimes that they may not give history. And such cases, we have even seen one case where a snake was found later in the bedroom of this patient with who had come with an acute renal failure. We saw acute tubular necrosis and subsequently found that it was due to snake bite. Okay, what about the right one?
It shows cast nephropathy, sir.
Cast nephropathy. So the cause would be
like myeloma cast nephropathy is possible, like hyaline cast.
Yeah, usually light chain
cast nephropathy.
Light chain cast myeloma is the most frequent cause. And how will you absolutely prove it?
We can do if you're thinking of we can do markers like SAA, we can do a kappa and lambda restriction, we can see.
Kappa lambda restriction. Frequently you can see. Sometimes it may not work very well, but that is the way. And the classic feature is the cellular reaction and the fracturing of this cast. These get broken down, see fractures, can see these lines in between. They break because they're very brittle, and the cellular reaction around. This is very, very classic. And when you see this, you can very confidently say that this is myeloma. And they may not have really made the diagnosis. So I think I will stop at this point. Thank you very much.
One question. Case 5.
Let's stop the screening.
Yes, sir.
I've just done the most basic ones only. This theme, you can make it more and more complicated, but essentially just to show you the way that you approach a renal biopsy. Okay.
Mona Lisa, are there any questions in the chat box?
Yes, ma'am. Yes, ma'am. One question is there. What can be, in case number 5, what can be expected picture of glomeruli? Hardly any glomerulus were seen.
I didn't hear that first part.
Arvindan,
In case
they're saying is
five-
that in the last case that was discussed by Alex, why are there so few glomeruli?
I mean, that's just a sampling thing. Maybe glomeruli are not destroyed. Glomeruli are well preserved in those cases.
Any other questions, Mona?
just one question. Only praises for the talk.
All right. Does anybody else have any questions for Dr. Arvindan? I think Arvindan, you've made it so simple that when they get back and they look at their next kidney biopsy, then they'll suddenly wish that they'd asked you questions. that always happens. I must say that I don't look at many kidney biopsies, and I learned quite a lot. Of course, I've heard you talk about kidney biopsies many times, particularly at Calipath.
Calipath.
Yeah, but each time I learn something that is different. So I'm sure that everybody has learned a lot. It's only that you have to go and apply what you have learned. And I think that is really the proof of the pudding. And I can tell you that if you go and do it after you have heard Professor Arvindan, you will have very few difficulties. Everybody has difficulties, but there is a systematic approach, which is what I like. You go very systematically and things fall into place. The jigsaw puzzle just gets filled up over there. Just for my own knowledge, since nobody has, oh no, there is a question there. Somebody has put it up. Divya Arora says, can we diagnose IgA nephropathy without immunofluorescence?
No. Too many causes can produce non-specific messenger proliferation. So you can strongly suggest that from the history of macroscopic hematuria combined with this histology, but without IgA, without immunofluorescence, you can't make the diagnosis.
Good. No, I was going to ask you, Arvindan. I think I must have heard you talk about it at some stage, but it's a very interesting thing as to how, the story of IgA nephropathy and, the galactose and, not being present in the IgA, etc. So would you like to just tell them? Because I think it's such a nice story.
So it's just that...
it's like detective work.
Yeah, well, basically, when I was a medical student, I had not heard of IgA nephropathy. With MD pathology, when I was doing, even then it was not a prominent. We used to call everything mesangial proliferative glomerulonephritis and stop at that. And then slowly this came into prominence and everybody realized that this is such a common disease when immunofluorescence was not very widely used in those days. So once with the increasing use of immunofluorescence, everybody realized this is such a very common disease. And there is some racial predilection or geographic predilection, I would say, not racial. And nobody knew what it was due to. Then somebody started looking at these IgA molecules and found that these are IgA is getting deposited against IgA, altered IgA molecules, where you have this glucose and galactose that is attached to that. If this is abnormal, then there is an immune reaction against that, and then they do that. Then they started doing some JIVAS studies, genome-wide association studies, and started looking for this. And then they found that these are very often there is defects in mucosal immunity, and so it may be food related or related to the bacterium, that in the gut. We don't know that part is yet to be unraveled, but there are some abnormalities in the gut and mucosal defense and mucosal immunity that is actually driving the whole process, and ultimately you are getting altered IgA molecules, immune reaction against that, and that is getting deposited in the kidney. So is there something in the food that we Indians eat, or the microbiome that we have, Indian microbiome, Chinese microbiome? These are the kind of things that we should now be looking at to arrive at diagnosis. So IgA nephropathy is actually a very, very, very fascinating story of science, progressing level by level, asking questions after questions. And I hope that the more comprehensive answers will be available in the next 5 years or so. And okay, some question I had asked somebody.
Yeah, there's a question there.
Yeah, one question.
Another immunohistochemistry test in the kidney biopsy other than IF and EM. Arvindan, it says over here, what is this other immunohistochemistry test in the kidney biopsy, other than immunofluorescence and electron microscopy? Did you hear me? It's in the chat box.
Could you clarify that? I didn't get that.
I don't know. I think somewhere along in your
IHC.
lecture, you asked about another test.
Maybe the question, maybe Dr. Arvindan, the question is, can you do IHCs in kidney biopsy in place of immunofluorescence?
Sure. Some people, some centers are very successful. They have very good results with that. But I have personally not been very, very successful with IHCs. And it's more costly also. And so mostly, I think everyone prefers fluorescence.
There is one reason why a lot of people have switched over to this. It's because of the you don't have to take pictures. You can keep the slides. You can archive them. They don't fade because immunofluorescence fluorescence fades. In that kind of.
That is true. That is true.
Yeah. So you have to take photographs and you have to store photographs, and you can't revisit your.
I have even tried cases in which you can't get you don't have glomeruli in the fluorescence. Another thing that we've tried is retrieval from the paraffin section and then doing fluorescence. Again, some people do it to get very good results, but again, I've not got equally good results with that.
All right, I'll just ask a question, Arvindan. Do you think that kidney biopsies are being done more liberally now than they were once upon a time, or the numbers of kidney biopsies are coming down because other investigations are, sort of pointing to the cause or the progression or the evolution of kidney disease?
I think renal biopsies have not decreased in number. In fact, for acute renal failure and all, the biopsies are increasing because the costs of acute renal failure, interstitial nephritis and all are also increasing. So for AIN and all, we get a lot of biopsies for acute interstitial nephritis. So I don't think there's been an overall decrease in numbers. And then not only that, for transplant, because of increased transplantation, we get a lot of load of
that is true. In transplant disease, it has certainly gone up.
We get a large number. In fact, we almost half and half. Our material almost half transplant and half others.
Mona, there are another two questions that have been asked.
PLA2R IHC in membranous nephropathy, is it seen only in primary membranous nephropathy?
Yeah, PLA2R. That's the one I asked you the first. Devika, who was the one who discussed that? Yeah. That is useful to pick up the primary membranous nephropathy.
So
that is routinely done now in all cases of MGN. That is done.
The question is that, is it seen only in primary membranous nephropathy?
Yeah, usually secondary like SLE or other things, you won't find that, no?
I think that
there may be, it is one of the antigens that is driving the membranous nephropathy. But there are other antigens also, but not that frequently, but we don't usually test that. So in those cases of primary nephropathy, which is not PLA2R positive, also maybe, some of them may be positive, but we don't usually test for the other antigens. And some antigens are yet unknown. But usually if it is PLA2R negative, we should also look for other secondary causes.
Right. I don't think that there are any other questions, Arvindan, but I'm sure that everybody will go away with very clear messages as to how to go about, very systematically go about, evaluating a renal biopsy. Certainly, anything that you learn has to be actually implemented, and I urge all of you to go do that the next time you have a renal biopsy and see how easy the whole thing becomes if you have got a system to work. Anything is easy if you use a system. Dr. Arvindan has shared his system of how he looks at a renal biopsy, and I would urge everybody to use it. Hey, because if one is, just jumping about from one thing to another, like we often do when we are describing our slides, then it doesn't really help, because somewhere or the other you are bound to to miss something that you would have otherwise done if you had a system with a checklist of what you had to do in a sequential kind of way. And really, renal biopsies and liver biopsies are very, very easy to sort out if you go in a systematic kind of fashion. I hope I've said that right, Arvindan, because I found that doing it systematically really does help.
Sure. And having this clinical correlation, after some time, after seeing many biopsies, you will the slides will start talking to you. Renal biopsy.
Yes, absolutely.
They'll tell you this is what I am. This is what I am. So that's
The slides talk to you anyway. Only we are deaf very often to what the slides are trying to tell us. That is true. Very true. Okay. So thank you so much, Arvindan. This has really, really been a pleasure. I always enjoy listening to good teachers, and definitely I enjoy listening to you. And
thank you.
I'm sure
Thank
the
you, ma'am.
others are.
Thank you, everyone. Thank you so
Thank you,
much.
sir.
Thank you.
Thank you, sir. And thank you, everyone. Thank you all the students for joining for today's discussion. And this is the upcoming talk. It's a lecture on HLA typing by Dr. Rajesh Sawant. He's consultant transfusion medicine and histocompatibility and immunogenetics at Kokilaben Dhirubhai Ambani Hospital, Mumbai. The lecture will be aired on Tuesday, December 20th, 2022 at 7 p.m.
And after that, on Thursday, we have a slide seminar. The second slide seminar, cases seminar on transfusion medicine. And this is basically on transfusion-related reactions. There are 5 cases to be done by Dr. Preeti Desai, professor from Tata Memorial Hospital. And after that, after the next week, we have now coming up 2 chapters on surgical path, male genitourinary and female genitourinary pathology. So we'll have large number of talks on GU pathology. And look forward to see you all. Thank you.
For attending.
Thank you, sir.
Thank you, sir. Thank you.
Thank you. Thank you all.
Thank you, sir.
Thank you to the moderators, Mona Lisa and Sankalp. Thank you to all the students who have, sort of put their diagnostic reputation, so to speak, on the line. And thank you, Kani, for standing in very ably for Ruchi. Thank you once again.
Thank you,
Have a
Kani.
good
Thank you,
evening.
ma'am.
All right.
Thank you, ma'am.
Bye-bye.
Bye-bye.
Bye.
Kani has to switch off. Kani has to stop the recording. Hi, Kani, you there? Anyway, I'll check Kani. So you guys can move. I'll be here. Hi, Kani. Thank you, students. You can say bye-bye and you can carry on, all of you. I'm just waiting for
Thank you, sir. Thank you, sir. Thank you, sir. Good night.
Thank you. Hi, Kani.